Can I have, thank you for the introduction, and thank you for the organizers for the wonderful arrangement and the invitation. I believe that, strongly believe that this, all these sessions will be useful for the postgraduates. And who are the students who are coming here?
I will announce their names.
Yeah.
Dr. Shamima Roshi and Dr. Sona Malik, Baby Memorial Hospital. Dr. Lavina Consera, Dr. Adira PK from Jubilee Mission Medical College, Thrissur. Dr. Neeti MM, Dr. Mary Chacko from Pushpagiri Institute of Medical Science, Tiruvalla. Dr. Ansi Rajan, Dr. Ashwati MP, Dr. Vrinda KV, Dr. Sharon C. Haru from MAS Medical.
So can you introduce from the left? Not clear.
I'm Vrinda KV from MES Medical College.
Yeah, this from this institute. Right?
I'm Dr. Sharon C. Harun from MES Medical College.
MES, Baby Memorial. Okay.
I'm Sana Malik from Baby Memorial.
Dr. Adira from Jubilee Mission Medical College.
Okay.
I'm Lavina from Jubilee Mission.
Dr. Neeti from Pushpagiri Medical College.
Jubilee Thrissur.
Tiruvalla, sir.
Tiruvalla. Okay.
Dr. Mary from Pushpagiri, Tiruvalla.
Tiruvalla. Okay.
I'm Ansi from Lourdes Hospital, Ernakulam.
Lourdes.
I'm Ashwati from Lourdes Hospital, Ernakulam.
Okay. So I will call by the institution's name, and so we'll have a small introduction, and we will discuss with the principles of operation. In between, I hope you have gone through the notes I have given. Even if you have not gone through, it's okay. It's not a big task. It's a simple session, maybe the simplest of sessions. And we'll discuss about the carbon dioxide waveforms and the clinical applications. Actually, Dr. Roshi and Dr. Sana has prepared some clinical situations. So in between, they'll be able to help you. And of course, we have to identify some pathological waveforms. So, to have the importance of capnograph, now it is considered as a definite ASA standard monitoring, without which if you give anesthesia, you will be land up in big soup if you land up in trouble. And according to National Health Service in UK, esophageal intubations undetected because you are not used to capnography is labeled as a never event. It cannot happen. You got the point. You should not give anesthesia without a working capnograph. And the closed claim analysis has shown that 34% of the damaging events involve respiratory system. And if you use the combination of pulse oximetry and capnograph, you can avoid 93% of the preventable mishaps. That's the importance. So, dear postgraduates, never start a case without having a validated capnograph. So, it gives the importance is that it gives the direct monitor of the partial pressure of carbon dioxide and the inhaled and exhaled gas, and indirect monitor of the carbon dioxide partial pressure in the arterial blood also. We'll come to that. And in healthy individuals, what's the PaCO2, arterial and tidal carbon dioxide difference is 4 to 5 millimeters of mercury. And when you see the increased gradient, you have many pathological conditions, commonly is pulmonary diseases or cardiac abnormalities. Now, some of you can say about the principles of operation. What are the physical principles of operation? What is the physics behind the operation of the capnograph? So, yeah, it's written there: infrared spectroscopy, mass spectroscopy, Raman spectroscopy, and photoacoustic analyzer. Which one is the one which is commonly used?
Infrared.
We adopt infrared. Can somebody say who is the pioneer of this technology? who introduced this technology? So you are appearing for quiz tomorrow, no?
Carl Friedrich left.
What is Sana?
Carl Friedrich left.
Full name?
Carl
Friedrich
Friedrich left.
Carl Friedrich
Left.
Luft. Okay. So he has introduced this physical principle in
1937.
1937. Okay. So you know the difference between the capnometry and the capnography. And the two types. What are the main types? Two types?
Mainstream and side stream.
Very good.
capnogram.
Mainstream and side stream. Okay. And you have time capnogram, and we will come to that difference later on in the next slide. Some of you can prepare and you can tell me the difference between the mainstream and side stream. And you have time capnogram and volume capnogram. Can someone say about the difference between time capnogram and volume capnogram?
In time capnogram, the carbon dioxide concentration is depicted against time.
Very good.
And in volume capnography, it is the carbon dioxide concentration is depicted against volume,
Very good.
expired volume.
What's the advantage and disadvantage? Do volume capnograph has got an inspiratory phase?
No.
No. But it has got 3 phases.
Yes.
Which is better for ventilation perfusion mismatch?
Volume
Volume
capnogram.
Very good. So, madam, they have studied everything. So, I don't have much to say. They will answer. So, and differentiated between the physiological dead space also, volume capnograph is better. But which one is do you use in our clinical scenarios?
Time capnogram.
Capnograph. Good. So, changes in capnogram value means there is a changes in metabolism, circulation, respiratory, and airway breathing system. That you should think of in that lines. Now, can someone describe about this?
Is the
Is it
mainstream
a
capnogram.
mainstream or a side stream?
Side
There is a clue. Enough and more clue is there.
Side stream capnogram.
Yeah, side stream. That's written as 6 feet. Sampling air. Okay. So how much volume does the sampling air consume? Usually?
50 to 500.
Okay, it's okay. Yeah, Miller it
ml
is
per
written as 30 to 500. 50 to 500 is okay. So what's the difference between these two? This is of course the mainstream. Yeah, go on, say.
The second picture shows the mainstream, whereas the first picture shows the side stream. The difference in the mainstream, we don't have to, the sampling gas can not need to be taken away from the sampling to the sensor or display. Then the disadvantages, it can increase the dead space, and there is chance of water vapor accumulation, which can increase the value of the EtCO2.
Yeah, that is the problem with the
Mainstream.
mainstream. How it is prevented?
Sir, we have an additional heating property to this
You
mainstream.
speak loudly, so
an
that it will
additional-
be useful for others also.
Sir, an additional heating property is there for the mainstream, maintaining the temperature above the body temperature, so that at 40 degrees Celsius, so that water vapor may not accumulate in that.
So,
And
okay.
it-
So you, rest of the students got that point. In the mainstream, you have to heat it around 40 degrees centigrade to prevent the water condensation. What will happen if water gets into the sensor?
Sir, a faulty increase in CO2, PET CO2 will be increased. It will be
Why?
shown like
Because water also gets
water also get sensed in this
infrared.
infrared.
rays. Yes. So that's why you want to make precautions while you keep it near the patient.
Yes, we'll have to usually cover in a gauze or something to prevent injury to the skin.
Okay, very good. So some of the points, and in the main this thing side stream, I cannot. There is a condenser there. You can see it here. So it works in the principle of gravity. So the condenser, that water trap you can see, no? I cannot point with this. Someone. Okay, there is a water trap, and with the gravity it condenses in the water trap, and you have to periodically clear the water trap. Okay, thank you. Now, some points. Erroneous results will occur if water enters the sensor, since it has got a high infrared absorptions. So one of you are described. And application of PEEP has minimal effect. It's around 20, even 1.5 millimeters of mercury with 20 centimeters of water increases oxygen, carbon dioxide reading. And effect of atmosphere pressure is eliminated by calibrating. That's why before installing, the technician will calibrate it. Now, can you describe the normal waveform from left hand?
It is showing time capture.
This is a time capnogram.
Okay.
It is written there. You can see that carbon dioxide there and time is there. So it's a time capnogram. And now you describe the phases.
Has 4 phases.
Yeah.
From A to B it is phase 1, and B to C is phase 2, C to D is phase 3, and D to E is phase 4. Phase 1 is it's dead space ventilation,
Okay.
in which there is no CO2, so it will not rise. It is from actually it is from the physiological dead space.
Very good.
Air is from the physiological dead space.
Okay.
And it's B to C, it is the
Can you hand over the mic? We'll give a chance to her also. You are answering very well.
Sir, in phase 2, that is B to C, there will be abrupt increase in ATCO2.
Why there is a steep rise in
There will be
carbon dioxide?
mixture of the alveolar gas, expired gas, along with the dead space gas. There will be increase. There will be mixture, and there will be increase in the ETCO2. And in C to D, there is phase 3.
No.
In C to D, there is phase 3.
Phase 3 is Roshi.
Phase 3 is alveolar plateau phase, which represents the gas coming from the alveoli. So then the end point of the phase 3, that is D, represents the peak end-tidal carbon dioxide, which correlates with the arterial PCO2. And there are then D to E is the inspiratory phase, which is represents the rapid fall in ETCO2.
Very good.
Then there are 2 angles, alpha and beta
Yeah,
angles.
we'll come to it. So, you have said everything. AB is dead space ventilation, BC is ascending expiratory phase, CD is alveolar phase, end-tidal carbon dioxide descending inspiratory phase. So, you should be able to say all these things. Now, there is 2 angles. Sana, you can tell about the alpha angle.
There are 2 angles. One is the alpha angle, which is between the phase 2 and the 3. Normally it is 100 to 110 degree, and it increases with increase in slope of phase 3. It is an indirect measurement of ventilation by perfusion ratio. And beta angle is 90 degree. It is known as the kappa angle. It increases in rebreathing conditions and decreases in obstructive conditions.
Okay. So now we'll go to a scenario. Next person, you can hold the mic. There's a 62-year-old male patient admitted in ICU following anterior wall myocardial infarction, suffered a cardiopulmonary arrest. CPR was started. Patient was ventilated via self-inflating bag. It was given self-inflating bag initially, and then patient was intubated. So this is the tracing.
The CAPNOGRAM indicates esophageal intubation.
Yeah, why you say it is esophageal intubation?
There is progressive decline in the carbon ETCO2 tracing. And
Yeah, you're right. There is a progressive. So what should you do?
extubate and re-intubate the patient.
So, as you said, we are removed the endotracheal tube, ventilated with the bag mask unit, and re-intubated. CPR is going on, and endotracheal tube tracing showing this.
The tracing shows ETCO2 of 10.
There is a progressive increase, we can assume. Okay.
If there is progressive increase in the ETCO2 tracing, it is an early indicator of ROSC, return of spontaneous circulation.
Okay. Is it a good sign?
It is a good
Effectiveness of yes.
CPR.
So, next slide. So, that comes to the point between the cardiac output and capnograph. So, with she has said that around 20 ETCO to around 20, it reflects around 2 liters of cardiac output roughly. Okay. So ETCO2 levels reflect cardiac output during CPR, and re-establishment of a perfusing rhythm is accompanied by dramatic increase in ETCO2. Around 10 to 20 millimeters of mercury during CPR is strongly associated with the return of spontaneous circulation, and capnographic findings in mixed ventilation perfusion or metabolic problems are difficult to interpret. Now, can you comment about this?
This shows the cardiac oscillation or the ripple
Yeah,
effect.
very good.
Whereas
Very
the
good.
end of the phase 3 and during the expiration, there will be multiple small like humps will be seen in the expiratory phase.
Okay.
So most commonly seen in case of pediatric patients due to the oscillation of the heart against the lungs.
Okay, very good. It's known as ripple effect. And now we'll go to second scenario. 56-year-old female ASA1 posted for laparoscopic hysterectomy. Endotracheal tube done and tube fixed at 19 centimeter after checking bilateral air entry. During surgery, patient is positioned in 30-degree Trendelenburg position. Now the peak airway pressure ETCO2 begins to rise. Okay, values are written there, and it was followed by saturation drop also. And it's showing like this. So definitely it shows endobronchial intubation. You have to reassess the air entry and recheck the tube. Okay. Now another scenario: 54-year-old male patient is posted for emergency laparotomy, intestinal perforation. You can give the mic. Is COPD, chronic smoker on regular medication with bronchodilators and steroid dose inhalers. Preoperatively, he was nebulized with salbutamol and budesonide, and IV steroids were given. G with endotracheal tube was done, and ETCO2 graph showed like this.
Sharp in appearance.
Yeah. What?
Obstructive airway disease.
Yeah.
COPD, asthma.
Okay. So what will you do?
You can manage with bronchodilators.
Yeah. Okay. You can deepen the plane of anesthesia. But you can give bronchodilators. That appearance, typical appearance, is known as sharp fin appearance. So can you comment about this?
In this, the baseline is elevated, and also the entitled carbon dioxide level is also elevated. This can be rebreathing.
Rebreathing.
Exhausted soda lime can be a cause.
Could be due to exhausted soda lime, or incompetent expiratory valve, insufficient fresh gas flow, or deliberate addition of carbon dioxide in the fresh gas flow. Sana, if you are there, can you describe this thing both?
In this case, we noted a gradual increase in the ETCO2 value. Over here, we saw that the inspiratory FI was 8, that is, inspiratory CO2 was increasing.
There is an increase in the baseline shift.
Baseline shift.
And the technician has changed the canister?
So the canister was changed, and the ETCO2 returned to the normal shape and the value.
Okay, very good. There's no change in the other setting. So elevation of the baseline of the capnogram can happen in the channeling of the gas within the carbon dioxide absorbent also. So Roshi, can you say what is the channeling? Channeling can also cause the same problem, or due to bicarbonate administration, tourniquet, sudden release of tourniquet, and inadequate fresh gas flow, hypermetabolic states. Okay. So what is this? Known as curare cleft. This is a capnograph of patient during lap anterior resection. Patient was changed to Trendelenburg position. Peak pressure increased to 38 from 22. And what's that? When the the position of LAR, lap anterior resection, patient will be shifted to the edge of the table. steep Trendelenburg position, in the lithotomy position, and you don't have the access to the airways, and the drapings comes on the tube, and there is a obstruction of the, always check the tube. So I'll add some technical errors also, which I have shared with you. So can you tell me about this? It's a technical error.
Too low sampling rate.
You can say loudly.
Capnograph is showing elevated baseline. It is seen in too low sampling rate.
With the side stream capnography, or can be due to low peak and elevated baseline. This is another technical error.
This is due to mixing of the expiratory gas with the fresh gas flow. It occurs when the sampling site is near to the fresh gas inlet.
Or when you are used to too high.
Too high sampling flow rate.
So this is certain situations where you have a capnograph, there is a dramatic increase in the CO2 reading. This is malignant hypothermia. It's a biphasic, which may not, you may see in one condition, but this transplanted lung is very rare. So peak, first peak is due to expired carbon dioxide from the allografted. You can hold the mic and say lung emptying rapidly, and the second peak is expired carbon dioxide from the native lung, which is emphysematous. The difference in the complaints could account for the observed biphasic pattern. Can you say in any other conditions where you see biphasic pattern?
Scoliosis.
Very good, excellent. Scoliosis. This is another scenario. Has got two humps, kyphoscoliosis. So pregnancy capnogram, anyone may want to make a comment?
In pregnancy, there is reduced FRC.
You can have a normal capnogram also. Okay.
There can be presence of phase 4 and increase in the slope of phase 3. Then,
you can sometimes have a phase 4 also. Okay. That's there. Now another scenario, 50-year-old meningioma excision, male patient or meningioma excision for in pressure controlled ventilation. Okay, after induction, right subclavian was attempted, BP drops to 70 millimeters of mercury, peak pressure to increase to 40, SpO2 drops to 78 after 20 minutes. And the graph is showing like this. It's a pressure controlled ventilation. Can you tell me?
It could be a possible pneumothorax. In pneumothorax, the shape of the capnography will depend upon the volume, tidal volume delivered, which is a function of the mode of ventilation. So in pressure controlled ventilation, there will be a decrease in the tidal volume and a gradual increase in the EtCO2 initially. When tension pneumothorax develops, there will be a decline in the cardiac output, resulting in a decrease in EtCO2.
Because of hypotension is there, and sampling air will be less.
It's less.
So can anyone want to comment about the capnogram in pediatrics? It could be normal, prolongation of phase 2 or increase in slope of phase 3, or prolongation of the descending limb. Alveolar plateau may be short sine wave capnograms. So you might have seen the sine wave capnogram in pediatrics. So can someone say about the increase in EtCO2, conditions which increase the EtCO2?
There are conditions which cause an increase in metabolic rate, like hyperthermia, fever, malignant hypothermia, sepsis.
You can classify everything into increased metabolic activity.
Seizure, shivering, then hyperthyroidism. These are the states which increase the metabolic rate. Then if there is a increased CO2 production, blood bicarb administration, increased catecholamine production or catecholamine administration, then parenteral nutrition.
Parental nutrition.
Hyperalimentation.
Hyperalimentation, okay. Next
Then,
person. Any conditions which decrease the ETCO2?
Decrease the metabolic rate. Hypothermia.
Okay.
Then hypothyroidism. Then conditions causes decrease in blood supply. Decrease in cardiac output. That will cause the conditions like pulmonary embolism. Then cardiac shock, hypovolemia.
Okay. You have not missed anything. Okay. Thank you.